cursor. And the investigators, in addition to me, are Alistair Young, who's at the University of Auckland, and he was the original developer of the Cardiac Atlas Project database as part of a R01 that was linked to the former NCBC at UCLA run by Art Toga. And we have Jeff Omans in the Department of Medicine, Jim Perry, who's a pediatric cardiologist at Rady Children's Hospital, Alison Marsden, who was here at Mechanical and Aerospace Engineering but recently moved to Stanford, and Lucilla. So cardiology, as you know, is very quantitative, and cardiologists want to know masses and volumes, hemodynamic quantities that can be derived from them, such as stroke volumes and ejection fractions, shape, chamber shapes and wall motions, measures of tissue function like strain and torsion, compliance and contractility. And so in our work, we use medical images such as MRI scans to build models, and from those models we can use them either for analysis of shape or mechanics, electrophysiology, or other physiological functions. And the idea of the Cardiac Atlas project is to use these models, which are parameterizations of the shape obtained from the medical images, to explore the statistical properties of shape amongst patients, for example, by doing principal component analysis of shape parameters, and then to recognize patterns and to classify shapes to better inform diagnosis. So the Cardiac Atlas project is a database of cardiac MRI exams and three-dimensional models that have been created from them. There are over 3,000 exams in the database, mostly coming from two studies, a study of asymptomatic volunteers called MESA and a study of patients with myocardial infarction called DETERMINE. And so as part of the Cardiac Atlas project, the group in New Zealand developed processes for uploading the DICOM files to the database, for de-identifying them, and for documenting that the studies were obtained with informed consent and IRB approval. And the access to the database is upon request. So the data are de-identified, but they're not anonymously accessible. You have to register for an account, and then you have to accept the terms of the different study investigators who own the data in order to examine them. One of the things that the Cardiac Atlas has done is use these data for challenges. So challenges in image processing, and challenges in modeling, and challenges in statistical classification. So the user of the database, having accepted the terms, can access the raw images, DICOM metadata, and shape models, as well as their statistical properties. So the application of this renewal of the Cardiac Atlas is on congenital heart disease. And it's actually on congenital heart disease primarily in adults, but not, we've branched out a little bit. Cardiac malformations are actually the commonest birth defect. And now, thanks to life-saving surgical procedures that were developed in the 70s and subsequently, most patients survive into adulthood, and so there are now actually more adults living in the United States with congenital heart disease than children. And those numbers, the oldest of them are sort of now mostly in their 40s and are starting to get to ages where risks are expected of cardiac complications such as heart failure expected to increase. So a lot of these patients have an operation called Fontan or Fontan procedure, which is a palliative procedure that's done in the children when they're when their pulmonary arteries are old enough, are large enough, but usually around about 2 years of age, that have these complex congenital heart defects. And the basic procedure shunts blood from the vena cava or the right atrium to the pulmonary artery. And the result is a functional single ventricle. Okay, so in this case, in a patient with tricuspid atresia, so no working tricuspid valve, there's only a working left ventricle, a residual right ventricle, and this ventricle has to pump blood through the lungs and through the systemic circulation and through the lungs in series. So the one ventricle is doing the job of two. So this study is really about single ventricle physiology, and the two main classes: a single left ventricle, such as the case of tricuspid atresia where I just described, where the right ventricle is residual and small, or the case of hypoplastic left ventricle, which is the other most common case, where now we have a single functional right ventricle. And these patients, even after they get past the early risk period when they're in early childhood, are at risk of developing subsequent complications such as ventricular dilatation and dysfunction, heart failure, and possibly sudden cardiac death. And it's very difficult for the cardiologists who manage these patients to assess this risk or predict when there is a need to intervene, such as with the implantation of an ICD. One thing that is interesting and somewhat unique about these patients, though, is that medical imaging is not only routine, but tomographic magnetic resonance imaging is routinely done and longitudinally. And so one of the first challenges we had to deal with in the Cardiac Atlas was extending the database so that it could handle longitudinal exams, because most cardiac patients don't get an MRI exam. Very few get longitudinal exams, but clearly we get more information from these longitudinal studies. So the aims of the project overall are to identify new early markers of compensatory or maladaptive remodeling in adult congenital heart disease patients with single ventricle physiology using Atlas-based magnetic resonance imaging derived models of ventricular shape and biomechanics, and to deploy these data models via the CAP database. And so our first aim is to create a database of congenital heart disease cases, initially comprising 60 single ventricle patients from UCSD, including follow-ups in at least half of them. The second aim has been to develop Atlas-based image-derived statistical and computational models of ventricular geometry and wall motion and their changes over time in this cohort of patients. And then finally, to start to use these parametric models of shape and geometry and our understanding of the differences between different patients to develop biomechanics, models of cardiac mechanics or fluid mechanics, wall mechanics or fluid structure mechanics, to understand the mechanisms of these maladaptive remodeling events. So the main job is to build these models for each patient. These are 4 models built of patients with single ventricles due to tricuspid atresia. And the modeling process is relatively rapid, but it is interactive. It's not automatic. We have an atlas, and the atlas is superposed on the 3-dimensional images, and then the user assists using guide points, the image processing algorithm, in finding a best match to a reference frame, usually at end diastole. And then the system automatically tracks the shape changes through the entire cardiac cycle. So these are 4-dimensional models of 3D shape and their changes during the cardiac cycle. Now, once we've collected enough of these, we can start to do principal component analysis on these models and extract principal modes of variation within populations. So this is in the asymptomatic population, and you can see the first 4 principal modes of the shape of the ventricle at end diastole. The first one corresponds to the sign. So this represents the mean shape of asymptomatic patients' left ventricles, and this represents plus or minus 2 standard deviations of these components. And so you can see the first difference between people's hearts is some have big hearts and some have small hearts. Okay. The next mode has to do with the sphericity. These are just descriptions I'm adding to these mathematically derived properties, but you can see that some people's hearts are more elongated and some are more spherical. This particular mode also combines valve orientation, but this mode, mode 3, is more influenced by the orientation of the valve. You can see in some patients the valves sort of are tilted at this angle, and others they're tilted at this angle. And then the fourth principal mode that came out of these large number of asymptomatic patients had to do with particularly the thickness of the ventricular walls relative to the rest of the shape. You can see that there is similar but not identical ordering of the modes at end systole. Yeah. So we haven't yet acquired and analyzed enough congenital heart disease patients in order to compute the principal components of their population. So as an intermediate study, what we've started to do is take the models we've made of these tricuspid atresia patients and look at the components of shape resolved from the asymptomatic group, taking the first 4 modes of the asymptomatic group. And so you'll see here are the 4 patients. The first thing that comes out is they're all completely different from each other, but they all have at least one mode that is more than 2 standard deviations away from the normal population mean. So in some sense, all of these patients have abnormal cardiac geometry, which came as no surprise. But what is more of a surprise is that actually every single one of them had a different difference. Okay? So this means that the patients with congenital heart disease have highly variable shapes, and that being able to classify what's different about them may give us a better understanding of the long-term outcomes. I mean, similarly in end systole, you can see that there's a little more of a concentration of similarities, but different modes in different patients show the greatest differences from the normal population means. So we're continuing. I think we have about 20 of these patients now, and so we're getting to the point where we can start to find how these differences start to relate to differences in the patient's presentation and eventually their natural history as we follow them over time. The other commonest case is the single right ventricle. And these patients are actually at greater risk of developing heart failure, and many of them, their condition is due to hypoplastic left heart syndrome. And people have proposed, based on animal studies, that a trigger for this underdevelopment of the left ventricle might be lower than normal hemodynamic loads, particularly in the left ventricle during development, particularly due to some sort of obstruction of the mitral orifice. And so in the biomechanics phase of this work, one thing we've been very interested in developing is models of growth and remodeling. And so we've developed a model of growth and remodeling in the developing and adult heart that's based on our experimental observations that when we stretch myocytes along their axis, they tend to get longer, and when we stretch them perpendicular to their axis, they tend to get wider. And so using this to define a growth rule, we can solve a biomechanics problem and predict how, under changing conditions, a developing heart would grow. And so we initialized this model to human data on changes in end diastolic volume and found that the growth rule that we've tested in other settings actually did a pretty good job of getting the changes in shape over with gestational age between 22 and 40 weeks. And then we said what would happen if at 22 weeks we decreased the filling pressure on the ventricles, and you can see that they grow less, consistent with the hypothesis that it has been advanced. And so then what we did is we matched this model to a patient who'd been studied at Rady Children's Hospital using data from 30 weeks, assuming there was no significant difference at 20 weeks, and because there hadn't been any abnormality noted at 20 weeks, and predicted what the the size of the heart would be at term, and you can see that the prediction is a little bit lower than the true size, but these models might be able to be used once we understand the mechanisms of development to predict in advance those fetal hearts that may be at risk of developing these chronic disorders. Finally, I just wanted to say that one of the issues we face in scaling this up is having infrastructure that will enable us to quickly get the images from the MRI scanner to the database. And so we've been working to use the XNet infrastructure to combine it with the Cardiac Atlas, which uses a DECM4Chi class library so that in the scanner we can press a button, send the DICOM file to the physician's desk. At the physician's desk in the hospital, he or she can go through a workflow that includes de-identification and integrating the de-identified DICOM file with other data from other exams, such as electrocardiographic and cath lab studies. And then when the data have been integrated and de-identified, then it can be uploaded to the database. So that's all I have, and I hope I haven't gone over time too much. Thank you. Thank you.